Prostate cancer remains one of the leading health challenges for men worldwide. Yet it is often surrounded by silence, stigma, and misinformation. Early detection can save lives, but many men still shy away from screening or ignore the warning signs until it is too late. Well, on this episode of Untangle, we confront the realities of prostate cancer, separating myths from facts and exploring what every man and indeed every family needs to know. As always, I am Blessing again. Welcome. Well, joining us today is Dr. Awuzie Donald, a urologist at the Federal Medical Center, Abuja, also a member of the West African College of Surgeons and founder of Healthies Global. Thank you so much for being here, Doctor.
Thank you so much. Thank you for having me.
All right, so let's go straight to untangling prostate cancer.
Okay.
All right, so when people hear prostate cancer, mostly they're confused, like, what is this? So can we start from the very beginning? What is the prostate and what happens when it gets cancerous?
Okay, so prostate cancer, otherwise known as cancer of the prostate, so is a cancer that affects the prostate gland. So the prostate gland is a gland situated deep inside the pelvis. So as simple as keeping it simple, the prostate gland has some functions, but however, it can be affected by this cancer we are talking of. So some of the functions include production of some of the fluids that make up the semen, which is where you also find the spermatozoa, sperm cells. So all of them together form the seminal fluid. So that's one of its functions. It produces these fluids. So then when it gets cancerous, it now becomes a prostate cancer. So prostate cancer is the commonest urologic cancer and also the leading cause of, is also the commonest cancer in our sub-region.
Oh.
Yes. So it affects only men because it's only men that have the organ or the gland called prostate. And it's a slow-growing cancer, especially in the early, if caught early, in the early stages. It's a very slow-growing cancer. And it's known that most men will die, more men will die, or fewer men will die of prostate cancer than from prostate cancer. So most men will die of other natural causes that are not prostate cancer. So it tends to stay there, slow growing, and these men will have it for a long while before it will even start disturbing. So it's a very slow growing cancer.
So now I'm definitely going to ask, what causes this?
Okay. So, being a cancer, most cancers, particular cause is not well understood. However, there are what we call risk factors. Then for prostate cancer, there are known risk factors. And these risk factors can be divided into modifiable risk factors and non-modifiable.
Okay.
So non-modifiable are those ones you can't do anything about. It's just there. So while modifiable risk factors are the ones you can actually manipulate, maybe change one or two lifestyle and get it done. So the non-modifiable ones include male gender. So the sex, as that you're a male, you already have a risk of having prostate cancer.
Okay.
So that's one. Then we have other non-modifiable risk factors like age. So prostate cancer is commoner in the elderly. So there's this, it peaks around 65 years to about 75. So that does not mean we don't see it in the younger people, but around that 65 and above, that's where you see the peak of prostate cancer. So the older the patients, the higher the risk and chances of getting prostate cancer. So that's one. Also, there is also a family, it could be familial. when a sibling has it or a father, it increases the risk of the patient or risk of chances of one having prostate cancer. So, and also genetic factors also. There's this gene we know as BRCA gene, BRCA1 and 2, especially BRCA2 genes. So people that have this gene are at increased risk of having prostate cancer, pancreatic cancer, ovarian, and even breast, both male and female. So that's it. So these are the non-modifiable risk factors. Sorry, I forgot. I left out ethnicity.
Okay.
So the black race is in the black race has a more aggressive type of prostate cancer than other people, and also with the more aggressive type of prostate cancer, yes. Then another challenge is that in our locality, the patients present late. You understand? So by the time they present, the cancer is already in advanced stages. So it can be put side by side with maybe in the Western world where they present early, they have more facilities, they have more education, even screening and all that to catch this cancer early. So most of our patients, by the time they come, they're already advanced or metastatic. Metastatic means it has left the prostate to other parts of the body. So this makes it more worrisome and challenging to manage. So we'll go over to the modifiable ones. So modifiable risk factors include there is dietary. So it has been noticed, or studies have shown that increased intake of fatty food like omega-6, arachidonic acid, also red meat increases the risk of prostate cancer, while things like fruits and vegetables are better, and things that have antioxidants, fruits have antioxidants, vitamin A, vitamin D can also help in preventing. Also, another risk factor includes obesity, which of course the fat will cause now. So exercise has shown to have some effect in prevention of prostate cancer. Then, of course, smoking increases the risk. So these are some of the risk factors, not necessarily the causes.
So the cause is not defined.
It's not well known.
Yeah,
so we
just
only have
risk
risk factors. It's cancer. Most cancers, you are not really able to pinpoint definite cause.
So now, since you've mentioned the fact that for us down here, patients always present late.
Yes.
Now, from the moment it is being diagnosed, okay, before we go there, how is it being diagnosed here?
Okay, so how it's being diagnosed here is most of the time, okay, I have to put it out there first that most of the symptoms of prostate cancer, about 70% of the time, is asymptomatic.
Okay.
That's the patient doesn't get any symptoms. It's just, like I said, it's slow growing. So the patient may not even know or have any symptom for a very long time, or may not even know. Some may even die of natural causes of all that. But however, some people also have symptoms, and this sometimes brings them to the hospital. Then another way is screening. Though screening is controversial, there's a school of thought that supports screening, some don't support screening. Maybe we'll talk about it later, especially in the UK and maybe US, where better health systems are in place. So basically, screening and clinic presentation. Sometimes they present in clinic, and also they can present as emergency, because some of them don't even know and they end up treating something else. They keep treating something else till when they are now carried to emergency rooms. So basically, these are the 3 stages where we get them: screening, clinic, emergency.
What are some of the very obvious symptoms?
Okay, so apart from the asymptomatic group, the obvious symptoms, when the symptoms are present, they can have things that mimic even normal prostate enlargement, benign prostate hypertrophy. So they can have lower urinary tract symptoms like frequency of urine, nocturia, urgency. Urgency is where you're not able to postpone urine. Like we are here now, we can actually, even if we are pressed, we can actually say after this interview. But the patient that has urgency cannot. So it's either you go or it starts coming out. So we have frequency also. Have nocturia. We have hematuria. Hematuria means blood in urine. Then also there could be blood in the semen. That's hematuria. Hematospermia, sorry. So hematospermia, blood in the semen. So some of these patients have this. So when it is advanced, you now start having things like low back pain. The patient starts having low back pain. At this point, when it gets to metastatic, the patient starts losing weight, bone pain, pathologic fracture. They can just take maybe small force or energy and cause the bone to break. Some may have paraplegia, inability to walk, nerve compression. And of course, the thing can get to other parts of the body. Recently, we started seeing people presenting with metastasis to the chest, to the lungs, pleural effusion, and other metastatic signs and symptoms.
Okay, so you mentioned something while trying to break this down.
Okay.
You said sometimes it may present as just so there's a thing with the prostate. You think it's just
benign hypertrophy of the prostate.
So what is that?
BPH is benign prostatic hypertrophy. The prostate it can be affected by a lot of things, not just the cancer. It's being an organ, it can be affected by other things. So it can get enlarged. That's benign prostatic enlargement. This one is not cancer, it's just an enlargement of the prostate. But however, this enlargement blocks the pathway. The prostate is just below the bladder and is a channel through which urine passes outwards in men. So it can actually obstruct the pathway. So the symptoms will be similar to what I just said, the urgency, frequency.
But does this lead to cancer?
No. It's independent. And a patient can have two of them. They can coexist. So also there could be prostatitis. That's infection or inflammation of the prostate gland.
All right. So when the moment this is being diagnosed, what should be the first line of action? Especially if it is diagnosed at the very later stages.
Okay, so it being a cancer, after diagnosis have been made with adequate counseling, yes, because you have to interact with the patients, tell them the challenges, tell them the prognosis. Prognosis means how it's going to go, the natural history, if this is done, if this is not done, how it's going to end up and all that, the life expectancy and all that. So after that discussion, is a cancer, so there should be a multidisciplinary approach. It's not just the urologist that manages prostate cancer.
Okay.
So at this point, you have to get the oncologist involved, oncologic nurse, the oncologists, and other aspects of healthcare that may be involved in the management of these patients. So that done, a risk stratification will be done because there are a lot of guidelines in the risk stratification. So you need to know whether it's a low grade, intermittent grade, or high grade disease. So this will now guide your management. Are you going to, since you said it's advanced or metastatic, so are you going to use hormonal approach? Are you going for radiotherapy? That's why I said a lot of specialists to put head together, not just the urologist. Because if you are going with radiotherapy and other modalities, even chemotherapy, the oncologist has to be carried along and has great input too. Okay, so I think we need to dissect all of the treatments that are available. Yes. All right, but before we do that, let's go on a short break. All right, now we go on a very short break. When we come back, the conversation on prostate cancer will continue. Please stay with us.
everybody has a stake in making the world a better place with love and compassion. As we thrive daily, we continue to strive to face the many challenges that faces our Earth because together, we all matter. On one side, we are exploring the captivating stories, the trends, the glamour, while on the other hand, we're looking at the love, the care and compassion from our champions. In our Stars Quiet Cove lies the burning passion for humanity, which is seldom known and unsung to the world. Join me on Famed to look at the flip side of your favorite beyond the regular.
For 2 seasons, Timeline has taken you on a journey of exploring real-life issues and solutions. Well, we are on to season 3 of Timeline, a space where we talk about real issues shaping our world. Here, we sit down with voices that matter, with people who are driving change and making impact. We are talking about more than just problems. We're talking about the attainment of our collective commitment, the global goals, the SDGs, and of course, our community-specific targets. Our conversations aren't just about highlighting problems. They're about finding solutions that truly works, solutions that touches lives and impact the globe, an appraisal of how close we are in meeting our global and community targets. We create rooms for honest, thought-provoking conversations, a ride that you wouldn't want to miss. Well, this is Timeline, where conversations lead to solutions that change lives.
Thank you so much for being with us. Well, now let's proceed to further conversations, especially as regards treatment. So, doctor, you were telling me about the several treatment options that are available. Let's break it down from the very beginning.
Okay, that means we have to start from maybe the early disease or when the patient presents and the different scenarios.
Okay.
So when a patient presents and the first thing is the clinical assessment. That's the clinical evaluation. We take history. If it's an emergency, sort it out, resuscitate the patient, then take history, clinical examination. Then you now get, that examination has a very vital component because it will end with a digital rectal examination, which we call DRE. Okay. So it's very, very important because it's going to increase your suspicion of the disease. So digital rectal examination, most men don't like this. So, but it's very important component. It's actually discomforting, but you have to cancel the patient and go ahead with it. So you put a finger into the rectum from where you can assess through the rectum where you can assess the prostate gland. So there, you assess the prostate, we check the surface, you check the size and all that just by examining it. So there are features in which when you see them, you'll be like, your suspicion will further increase. When the prostate gland is nodular, when the prostate gland is hard, when the prostate gland is asymmetrically enlarged, when even the mucosa is not freely mobile and all that, that will increase your suspicion of cancer of the prostate. So from there, the next thing you do is investigations. So you now start with, you do a PSA, prostate-specific antigen. So I must mention that prostate gland the prostate-specific antigen is organ-specific, but not disease-specific. What it means is that when the PSA goes up, you already know that it's coming from the gland itself, but you can't stick out your neck and say, is this particular disease? Remember, I mentioned a lot of diseases that can affect the prostate. So the enlargements, the benign prostatic enlargement, prostatitis, cancer of the prostate, all can elevate the PSA. That's the prostate-specific antigen. So, but when you have an elevated PSA, it further strengthens that your suspicion that you got from the DRE. Sometimes DRE may be normal and this one will be high, but at a level, we now go for the definitive investigation, or the definitive investigation, which is histology. This means you have to do a prostate biopsy. So biopsy means you take this prostate biopsy means you take small pieces of prostate from the gland and send for histology. So this histology will now clear your doubt whether this is prostate cancer or not. The pathologist will do everything, check under the microscope and all that, and now send the result back to you that we are dealing with a prostate cancer, or no, it's just a normal prostate or just benign enlargement and all that. So when you've gotten this, to further stage the patient, you can request for a multiparametric MRI, which also scans the prostate. So you need these three things: the multiparametric MRI, you need the PSA, and you also need the histology reports. I forgot to mention that the histology report will give you the Gleason score and some other things. So with these three things now, you can now risk stratify the patient into whether it's a low-grade disease, intermediate disease, high-grade disease, blah, blah, blah. Let me not confuse it or confuse the audience. So with the stratification, you now know whether the type of treatment to go for. So it can be an early or localized disease. Localized disease means that the cancer is just on the prostate. It has not gone out by any obvious suspicion. Then it can be an advanced. It has moved outside the prostate, but has not gone far. Metastatic means it has traveled to a distant place, maybe to the bone, to the brain, to the chest, and all that. So this will guide your management, your treatment plan. So if it is localized disease, the target there is to achieve cure. That's what the aim is to achieve cure, the goal. So you go ahead and do what we call radical prostatectomy or radical radiotherapy. So what it means, radical prostatectomy simply means removing the prostate now removing the prostate, the seminal vesicle, and connecting it back directly from the bladder to the urethra. So, but in this line of management, your aim is cure. Yes. But if it is advanced or metastatic, your aim may not be cure. Your aim is not cure. So your aim is to slow down the progression of the disease. So another line of management comes in. So for advanced and metastatic, you can do androgen deprivation therapy. So in androgen deprivation therapy, there are two main ways we do it. We achieve that. You can do bilateral total orchidectomy. That's removing the two testes. Or you do a hormonal approach. So it's either a surgical castration or medical castration. So I must mention that while you are removing the two testes is that studies have shown that what feeds the cancer is testosterone, an active form of testosterone called dihydrotestosterone. And this testosterone, which converts to the dihydrotestosterone, is produced by the testes. So removing the testes is more or less problem solved. You understand? So nothing is more, the testosterone and dihydrotestosterone is like the fertilizer feeding the cancer. So you are now removing them. So if you remove the testes, no more production of testosterone at that time. Then the medical one, that's pharmacological, is to give a drug that blocks the pathway in which, that one you don't necessarily need to remove the testes, but you give a drug that blocks the pathway from the brain that signals, there's a chain of signal that signals the testes to produce this testosterone. So either way, studies have shown that both of them achieve the same thing, but the same result, but there's still a challenge. Most men wouldn't want their testes removed. So you have to cancel and cancel. Why the other drug is also expensive and is 12 weekly. So the pros and cons. I don't want my testes removed. That means you have to have money to sustain this treatment and all that. So after that, there are other lines of management, because at some point this one may fail also. The body may find another way of producing testosterone that is not testes. So that one is just a lot of other pathways. So other lines of management will come in. Chemotherapy, radiotherapy, and all that. That was why I mentioned the oncologist. Actually, so a lot of people will put hands together to make sure this patient is well managed. Yes, so
Wow, that's a lot. So at what point exactly does this... Okay, you mentioned that the testis might be removed as a form of treatment. So apart from that, is there any surgical procedure that is needed for treating the prostate cancer?
The removal of the testis is a surgical procedure.
That's the only surgical...
No, remember I mentioned radical prostatectomy for early or localized disease, where you are trying to achieve cure.
Okay.
Because I explained that the cancer cells are still inside the prostate. So if you remove prostate, problem solved. But these other ones, advanced and metastatic, it has left. And there's no way you go and be chasing all of them wherever they are. So you now do the removal of the testes. So you have to cancel the patients very well. Because removing testes means the testes produces the sperm cells. So that means fertility is gone. So you have to talk with your patient, cancel them. Have they completed their family size? Are they willing to go for this? If they've not completed, do they still intend to have children? Do they want to go for sperm banking and all those things?
Wow. So at what point exactly does one need to understand that it's either I cure this, treat it, or it's like death? Does it?
All these things are discussed in the clinic when they come, and maybe in informal ways like this also. Yeah.
All right, thank you so much, Doctor. Let's talk about technology, because this century, definitely we can't talk about healthcare and not mention technology. Of course, your surgical procedures involve the use of technology and all of that. But where exactly are you when it comes to treating prostate cancer and maybe some advanced technology now in Nigeria compared to other places?
Okay. So there are for the early cases, the localized disease, where you have to do the radical prostatectomy. There are other ways, not more or lesser invasive ways or minimal invasive ways. You can do laparoscopic radical prostatectomy. You can do robotics. Robotics, I don't say it's not done in Nigeria for now. Maybe we'll get there one day. But robotic surgery, robotic radical prostatectomy is done. It has better precision, and also laparoscopic. I think it has been attempted in some places in Nigeria. So with all these advancements, I think it's also for the benefit of the patient.
Well, thank you so much. I think you've been able to successfully break this down. But before we go, just one more question.
Okay.
What are some common myths? I mean, being in this space for quite some time, people get misunderstandings, or they just have some myths in their head that limits them from accepting maybe treatment or from just even going to get diagnosis. What are some common myths that you've come across concerning prostate cancer?
Okay, some of the challenges we have in management of prostate cancer is that sometimes the patients, they feel it's a death sentence, but it's actually not. Like I've said, it's a very slow-growing cancer, and most of the patients will, more patients or fewer patients will die of prostate cancer than from it. So they just believe there's this group that believes it's a death sentence, and depression and all that will set in, and of course, that may even worsen the prognosis. Then also there's this other set of patients that will not come from medical care and all that. They will rather go for maybe herbal, even more spiritual care, so to speak, and all that. So by the time they get to the hospital, the case is
advanced.
Now, yes, it becomes an issue, a big issue for us to manage and all that. And most times you don't achieve the best care which you could have achieved had it been presented earlier and all that. So
thank you so much. Now you have an opportunity to probably untangle prostate cancer to someone out there who may be so confused about it. How will you untangle this to someone? What will you say to someone that is really in need of education concerning prostate cancer in one sentence? One sentence.
Okay, still to remind the patient that it's not a death sentence, and early presentation management gives us the best outcome.
Thank you so very much, Doctor,
You're
for
welcome.
joining us
You're
for this wonderful episode.
welcome.
All right, now this is where we draw the curtains on today's episode of Untangle. We've been able to talk about prostate cancer, and just like Dr. Awuzie rightly said, it is not a death sentence. If you notice anything, please go for checkup, go for diagnosis, and hopefully you get treatment or you get cure. My name is Blessing Dagin, as always. See you next time.